Okay, so just about to start our last talk before lunch. So Mark Halling-Brown from Royal Surrey County Hospital, who's come over here on a very hot day, about 30 minutes walk, I think it is.
No, actually, I've walked from the car park, that massive long distance, but I've managed to get hot in that very short walk somehow.
Right. And so Mark will be talking about practicalities of creating a medical image research database.
Yeah.
So over to you, Mark.
Thanks very much. Yeah, so I head up a section at the hospital called Scientific Computing, and one of our various roles is to do some areas of research, and a lot of that involves helping out with forming databases and helping out with AI. And so I'm going to talk to you about the practicalities and experiences we have with forming quite a large medical image database that's used very actively at the moment, called OMI-DB. So I'll give a bit of an introduction and then end up talking specifically about that database. So I'll give a very, very brief introduction to AI applications in imaging and video, because I'm sure you've already covered quite a lot of that. So it'll just be some flashing up some nice pictures and things. And then I'll home in a little bit on more some of the healthcare AI applications that my group's aware of and the things that are going on out there. And then use that as a segue into talking about what we've actually done with the CR UK funded grant called OMI-DB and the spin-offs and things that have come out of that. And then specifically focusing on how we've put together the very large data set that's enabled all of the AI that's gone around it. Okay, so yeah, these are just some quick slides. As I said, you're probably already quite familiar with all these. So I just kind of outlined what I refer to as the AI revolution, sort of starting really with one of the first very successful CNNs as AlexNet. And then looking at some of the improvements over time, over the next few years, getting down to ResNet, where you actually have an error rate less than a human on the image classification sets, which is really rather impressive in such a short amount of time. So again, something you've probably already seen is high-speed image segmentation, which is obviously very useful in healthcare, as we'll see. Image captioning as well. These are all ambitious applications using AI. And then one of my favorites is actually image super resolution, which I think is really fascinating. The way the performance of the machines there is really quite remarkable. Looking at the machine generated image in the middle with the actual ground truth there, it's really quite amazing. Oh look, the videos actually work, that's amazing. So yeah, again, human pose estimation, again, all these applications, I'm just flashing them up quickly just as a segue into the healthcare. It's just, these all are very interesting to me. I'm fascinated just to watch the videos even now, in fact. And then looking at the world through the eyes of a Tesla and seeing how it sees the world again is really quite amazing, isn't it? It seems a better driver than I am. So all of those different applications have fed into the healthcare world as well. I did have lots of labels. Let's see if I can remember any of these. So you've got mammographic mass classification. You've got segmentation of lesions in the brain. You've got leak detections in the airway trees. You've got diabetic retinopathy classification. You've got prostate segmentation, lung nodule classification, breast cancer metastases detection in lymph nodes, that is, skin lesion classification, bone suppression in x-rays. You can see all these huge number of applications of AI in healthcare that are becoming a reality over time. So all of these different applications have their different challenges. So we're going to be covering quite a few of those, especially in the world of medical imaging. But they're all quite generic. Obviously, training data is obvious. Getting access to large amounts of training data is a tough one. Making sure that the system is generalizable, making sure it can perform well on new examples, but also that it can perform well on on examples, different examples within your test sets. And then looking at interpretability, which I know you've already had some lectures on. So understanding how a decision made, and also understanding how to relay that information to the user. If we're talking about a clinician now, making sure the clinician actually can interact with the AI algorithm in the correct manner, which is something it's very hard to get right. So moving on to healthcare applications, people are probably familiar with the Babylon Health chatbot. Yes, you see him nodding around there. So yeah, this is a good example of kind of a mixture of natural language processing and deep learning based inference engines. So I would say this, in my opinion, is a little controversial still. I think the evidence isn't fantastic to back up the claim of Babylon being great at being able to diagnose health issues. It is a bit disputed, but the fact that it's out there and being used does go to show that there may be some issues with the regulation of emerging technologies like this, which is a real big issue, especially in healthcare. One of my favorites is synthetic image generation. I think it was mentioned that you already covered some GAN networks. So this is exactly that. So you have two networks in parallel running, one to generate the synthetic images, the other to test to see if they look realistic, allowing you to generate your own massive data sets to then train your algorithms for, say, classification or detection. So this is a really nice approach to make use of these GAN networks. So moving on now a bit more specifically into the area I'm going to be focusing on, which is going to be breast screening. So this is mammography images. So there's already a few products actually FDA cleared and out there which claim to be using AI. Again, some of it's a little bit controversial as to how much deep learning is in there, but there's products such as Transpara, which is a mixture of CNN and traditional feature detection methods. But the evidence, one of the good things about the Transpara products is they have a lot of publications associated with their product, which is fantastic. Other companies don't necessarily show us that. And so you can actually see how Transpara does. And although you can see that there is a very small improvement here, you see the dark blue line is the Transpara against 115 radiologists. You can see there's a small improvement. It's enough to get FDA clearance and say this is a good product to be used. So this is Transpara on its own, operating as if it's a radiologist. So you can see Transpara is now operating as good as an average radiologist. So that's really quite impressive. We're already there, that we've got a product we can buy right now, pay per scan, and have as good as a radiologist. But actually, more realistically, certainly in the short to medium term, we're looking more as a decision support system, so using a computer-aided detection algorithm to support a radiologist. So these are the results from where Transpara has been tested with radiologists looking at images on their own, and then a month later looking at those with Transpara, and the order in which they did that was randomized to make sure that the effect of them remembering things didn't occur too much. And you can see on this bar chart here, the dark blue line is the detection rate with Transpara, and the green line is unaided. So you can see there's undeniably a very small but significant improvement when using the CAD over without the CAD. And this is a big deal because all the previous generations of non-CNN CAD didn't ever have these results. So this is actually beginning to work. But what you can see here, there are some cases where it hasn't affected at all. Can anyone guess what maybe these three guys here are? These are very, very experienced radiologists who are very resistant to using a CAD and don't think it will really improve their abilities. And these other ones are often inexperienced readers. And so that does tend to be the pattern so far, is that these are very beneficial to readers who are, one, maybe inexperienced, and two, maybe more open to the idea of using the tools. But obviously we're looking at an evolution here. So just a quick plug for our department. So we've got our own AI activity going on, which is why I'm here. So within medical physics at the Royal Surrey County Hospital, I think it's that direction, is it? So we've got various AI in the breast screening program. So in-house, we're looking at predicting breast density, which is something that's very important to looking at risk of cancer occurring, and then associated with that, looking if we can predict risk of a woman of obtaining a cancer within a certain amount of time. And then we've got various collaborations. One of our public collaborations is with Guildford DeepMind, developing a CAD using our data sets. And then we've also got a joint PhD studentship, so we're trying to open up outside of mammography. We don't want to just do mammography, so we're looking at nuclear medicine imaging and looking at detecting esophageal lesions in PET-CT. So sort of the things we're doing when it comes to risk is looking at things like this, so looking at very fatty breasts to very dense breasts, and looking if we can predict these accurately enough in order to stratify women into different screening patterns. So for example, a very fatty breast might actually be downgraded to a 5-yearly screening program, saving the screening program money. And someone with a very dense breast might be screened more often or with different technologies. And so that's what these AI products might enable. But of course, all of our work comes with its own challenges as well. One of the big ones coming with medical imaging is that they're often very high resolution. In fact, they're often enormous. And when it comes to 3D data, so what in breast screening that would be called tomosynthesis. So that's kind of a bit like a small view of a CT, so a small angled CT. These are sometimes up to 2 gigabytes per image, so these are really quite enormous and put some major challenges in training. And of course, there's difficulties, which is one of the big areas of this talk, is the data collection, the privacy, and the labeling. So getting all of that right is quite challenging. And the availability of the data as well, actually getting access to it. I think I missed out that there, yeah, the availability there. And then things like trust and acceptance and legal frameworks and evaluation, these are all really, really big deals and things I will touch upon on this talk. Okay, so moving on to kind of the main chunk, really we're looking at using Optimam as an example to frame the sort of challenges we've had while trying to collect images from multiple sources and centralize them and then share them for AI purposes. That's the general gist of it. So what I'm going to cover is tell you what we've got in our big database, tell you what it contains and what we first developed it for, because it wasn't originally for AI at all. This is quite a mature database, so it kind of existed before the big world of AI. And what we're using it for now. And then I'll move on to more specifically what makes the database useful, and then use that to show examples of how we actually enabled that in the database and the challenges we met. And then I'll tell you a bit about what we're up to in the future as well. So we've got a great big database. We've got several great big databases. I'm going to focus on the Optimam mammographic image database because it is by far our most mature. But we're looking at here large-scale, properly curated databases are required for AI. That's just a fact. You need very large databases for these. So on this slide here, we've got a kind of nice graphic of some of what our overall schemas look like. But really what we end up with is a very large curated mammographic image database that collects from multiple sites. And to be very clear, it's fully de-identified at the point of collection. So does anybody think that we gain consent or don't gain consent for that? You think we do? Does anybody think we don't? Hands up, anyone thinks we don't? So if I just show the next slide, so we've got 150,000 clients in the database, just over 2 million images. Did the people that think we might have still think we gave our consent? So we don't. The reason we don't get consent is it's not feasibly possible to do so. So we're collecting data retrospectively often, and the scale and size of the database means that it's actually not possible to gather consent. But under the NHS Constitution and GDPR, de-identified data can be used for research without the need to gain explicit consent for that. And indeed, breast screening is undertaken without the explicit consent of the people attending. It's implied consent by them attending the screening centre. And so that means that we are able to collect this data without consent as long as the data is collected from the specific screening site by an authorised member of staff, authorised to see patient data for whatever purpose, and that no patient information ever leaves. So the only information that ever leaves the site is de-identified data, so it's no longer patient information. So this can be a bit of a controversial point. People sometimes react to that in different ways, but that is the way it is now. That's the approach a lot of people are taking with forming these very large databases. And indeed, really, it's a barrier that needed to be overcome in order to make it possible. So when we obtained our ethical approval for the first round of Optimam a long time ago, so sort of 8 years ago, we were explicit in our processes, and the HRA REC committee was very clear and open that that process is fine so long as only data managers access the data. Any researchers involved can never access the actual collection sites. And so we do various things, like we put up leaflets like these and information sheets for the staff at the screening sites that gives them all the information about what the data is going to be used for, and what the future potential use of the data is. Because that's something that's quite clear as well, is that we're collecting this data initially for a grant called Optimum. And as I'll show you in a moment, that wasn't really anything to do with AI. So our initial ethics application didn't mention it. So our renewed application mentioned our interest in AI, but also mentioned our desire to share the data with the community. So share it with other research groups and commercial entities in order to stimulate artificial intelligence in the breast screening program. And so at that point, the ethics approval changed to allow us to do that, to basically to share the data on. And that's might sound relatively obvious, but actually that's quite a new thing. So the sharing of research data in that manner is quite new, and the manner in which we've done it is relatively new from our understanding. So just going back here to the bottom point, so it's a live, active database. It's a kind of a key point really, because it's not just a static shot in time of a patient's record. We need to know about these patients ongoing. So for example, if we collect a normal case from 2014, a woman attended screening and didn't have a cancer, and we want to train that using an AI system, what happens if in 3 years' time when she revisits for screening, she developed a cancer? That means we've erroneously used an image that actually may have had a very small cancer in it to train a system to say it didn't have cancer in it. So we do need to keep up to date with the patients that we collect in order to look at them over time. And there's other advantages to that as well, which we'll come to in a moment. So the setup of the kind of collection systems and the management systems that we put in place need to be able to update all of the data we have and keep it up to date. So for that purposes, we have to use what's called a pseudonym. Everybody happy with that, I assume? Pseudonym, so we just insert an ID, and that ID is stored at an encrypted database at the collection sites. So the systems we put together are able then to re-query all of our clinical systems using the pseudonym lookup to see if the patient has revisited. Okay, so yeah, there you go. That's the sort of numbers we have in the database. It might not seem large compared to other sorts of databases, but actually for a medical image database, that's really rather large. And you can see we've got around about 9,000 malignant cases in the database. And that's quite a lot as well. So breast cancer prevalence is around about 1%. So every 50,000 women attending screening, you would expect roughly around about 500 cancers. So we've got almost 9,000. So we'd need, I don't know, 90 million normals to make it representative. You know, so that's it's quite a large number of malignant cases we've managed to attain. And so we've got a large number of normal cases, but nowhere near the level to be prevalent. But again, that's not a problem because one doesn't need to train your machine with an exact prevalence set. You can train your machine with a weighted set as long as your validation set has a good prevalence in it. And we can form those sets from these relatively large number of normal cases we have. So the database contains DICOM images. Is anybody happy with what DICOM images are? Does anybody not know? It's just a simple file format. You know, it's just a file format with the image in it and lots of metadata attached to it. So patient name, patient ID, patient sex, date of birth, that sort of thing. So currently we have full-field digital mammography, DBT, which are these tomosynthesis I was referring to earlier, the very large files, some MRI and a scattering of others. But importantly for AI is that the images really aren't very much used without some ground truth and some background associated clinical data. So we're very fortunate in the breast screening program that we have a thing called the NBSS, which is a centralized database, which is relatively common to all the screening sites, and they all have similar-ish versions, which means that we can automatically extract information out of that clinical system. So these are the sort of things that sit in there. So you get your full patient history, their screening, if they've returned to assessment. I suppose it's worth, so people will attend screening, they'll have some images done. Those are read by a reader. If they find something suspicious, they don't know if it's a cancer yet, they just think, I think it might be, then the woman is recalled for assessment, and so further imaging then takes place. That's maybe a few weeks later, and then those imaging are assessed, and if a biopsy is taken as well, that's sent off to see whether it is a malignancy. If it's a malignancy, then they go on to have treatment and surgery and so on. If it's not a malignancy, it's a benign biopsy, they get returned to the routine screening program. So all of that information is stored in this system. So all the pathology information, the surgery information is all stored there. So you can see it's quite valuable to classify these cases. So of particular interest, I alluded to the readers. So actually in the breast screening program in the UK, we have 2 readers is by law. So you have a first reader, second reader. Often the second is blinded, not always. And then if there's a disagreement, you get a consensus read. And quite often you have a further consensus read. So you have a lot of readers, especially compared to other countries. And that information is actually stored. All of their opinions is stored. Can anyone think why that's really useful for AI?
Gives you confidence.
It does, yeah. Maybe what about the evaluation of using AI? Say again?
Gives you ground truth.
It does, and it gives us the ground truth of what individual radiologists thought. So we could slot the AI into position 1 and tell how it would have performed retrospectively on a set. So we don't actually need to go out and trial this in a live clinic. We can actually trial it on these data sets, how it would have performed in a first, second, and third read, because we know the other people's determinations from it. So it gives us a really powerful evaluation point, that is. So we have, as I mentioned, there's lots of pathology data points. These are really valuable. I'll allude to this later on. So cancer subtypes, tumor size, the common mutation statuses that are detected by the pathology processes. We do have the full details of their treatment information and various other calculated points. The thing we do miss, which is a real shame, is that when they finish treatment within the screening program, that's the end of it in that database. It doesn't follow them up. That happens elsewhere in the myriad of NHS systems that exist. And so we can't follow them up long term to see outcomes, which is a pain, but it's the way it is. So one of the things that's missing, it's always a bit of a laugh really, is the actual location of the cancer. So none of those processes that I just described actually record where the cancer is. In most places, there is normally a piece of paper with a kind of side-on view of a breast with a little pen drawing where the cancer roughly is and a line coming off saying lesion A, malignancy. It's not drawn on the image, it's not recorded anywhere with coordinates. And that's a real pain, because to make it useful for AI, we do need to know where the cancer is so that the AI can be trained on those specific subregions. So we've had to go through the processes of feeding those images back to expert radiologists to allow them to annotate the cases. And I'll talk more about those processes in a moment, because those are quite arduous. But those are the sort of things we find, like where is the actual cancer, draw a box around it, what size is it, what type. The conspicuity describes how hard was it to detect for the radiologist. So originally Optimam has existed for 10 years. It's 2 CR UK funded program grants in a row, and now it's an ongoing maintenance grant to maintain the database. So originally it wasn't anything to do with AI at all. The database was required to aid our various studies investigating the effect of different factors on cancer detection. So different manufacturers, different image processing algorithms, how do these affect how humans detect cancers in images. So we ran lots of image perception studies showing images remotely to radiologists to see how they perform. But of course, we then realized it was useful for other purposes, so we began the process of establishing it as a research database, and then therefore allowing it to be shared to other people. But obviously, that's moved on somewhat. So right now, these are non-AI uses. I thought I would just highlight a few of these. So we're using it as a training infrastructure. We're using it to look at things called interval cancers, which are cancers which occur between screening rounds. And these are really interesting cancers because they should have possibly been detected at the previous round. And indeed, quite a lot of the new AI products seem to be really good at detecting interval cancers over humans. So things like technical recalls, when there's blurs in the image, we're looking at automating approaches to detect those so that we don't have to re-invite women to come back a few weeks later causing stress, and lots of other various uses. But for AI, these are the kind of main areas that the database is being used for at the moment. So CAD, be it detection or diagnosis, prediction of breast density and risk, as I said, and triaging of mammograms. And I highlighted that these are the 2 areas that we particularly are working on, but we are collaborating with lots of people working on these areas. And those collaborations are enabled by the fact that we are able to share our images and data with other groups and companies to support our research activities, to support their research activities and their developments. So currently we're sharing with, this is a little out of date, somewhere in the region of 55 groups now. So it's quite an active database. And I will highlight this as one of the big challenges to enable AI is actually the logistics of sharing such a large amount of data. So what I'm going to do now is just run through the aspects of our particular medical image database and what makes it useful for AI. And then I'm going to pick on some of those to tell you how we enabled that. So that's where the kind of practical bit comes from, the challenges. So lots of things make it useful. Oh yeah, I should have come to this slide to say what I just said. So I'm going to focus on de-identification of data. I'm going to focus on getting the architecture right to enable the scaling up of the collection. I'm going to focus on marking, so getting our cases actually annotated, and then talking about the sharing, which is a really important part if this is actually going to be used. So proper de-identification is something that makes our database very useful because it means that we can establish it as a research database and then share it onwards because it's been properly de-identified. So just quickly, just to give you, I mentioned earlier the DICOM format. It's just simply a data set with a list of elements. So these are all different tags. This tag here is patient name, and this is the patient's name. This tag here is their age. This tag here is their, I don't know, I think it's job or something like that. And then there's another tag for pixel data, and that's where the image is. So it's just a file format. So de-identification is the process of choosing which of these things have patient identifiable information and then removing it, which does sound relatively simple. So there's a supplement to the DICOM standard called 142, which tells you how to do that. It actually lists all of the tags and how they should be dealt with. So again, that's relatively simple. One of our first activities almost 8 years ago was to test the various solutions out there for doing that, the software systems, and found actually most of them are really poor. In fact, we never found one that completely complied with DICOM 142. I'm sure that's improved now. So that and other reasons, we developed our own solutions, basically meaning that we could 100% tick the box for DICOM 142 compliance, and that we could integrate it into our kind of pipelines, as you call it, lots of different circumstances that we might use this. We wanted it to be customizable. But can anybody, so that's the kind of DICOM tag, so that's making sure you don't have someone's name or their address in there. Can anyone think of what else challenges might be presented by a medical image when you're anonymizing it? What else might there be that's identifiable? Shout it.
Piercings and things.
Yep, quite right, yep. Anything else?
Maybe even the vein structure could allow you to re-identify something.
Theoretically, you're getting into kind of PP there, which is potentially identifiable private information. Yeah. Yeah, quite right. Well, that's a really, really good point there, is that actually a lot of the data often has burnt in images, which has been burnt onto the actual pixel data, burnt in words and text and things like that. Quite often people take screenshots, and it often has the patient information as an overlay, and that gets embedded on the image there. So that's a real big challenge. And you get people who take old x-rays because they want to have the historic record and digitize them, and those x-rays will have patient information on the bottom there. And actually there's some, I've got a list here, yep. So you've got burnt in data, digitized scans, screenshots, and actually some of the manufacturers either embed the technician's initials onto the image. So that's the person who took the image. So that's not patient information, but it's potentially sensitive information. So these are all really big challenges, and these are things that people quite often underestimate when trying to collect at scale. So we've ended up building an actual AI-enabled tool to prepare our data set for AI in order to detect various text abnormalities, and in order to detect these initials, technicians' initials, because they come encapsulated in a little box like that, but the box can be absolutely anywhere. And it might be overlaid on some tissue, it might be overlaid on some instrument, on a biopsy plate. It's really hard to do. So we've had to enable tools to do this. So again, these aren't the sort of things that we thought of when we started this project. We didn't think we'd have to do such complicated things. So what have we learned about de-identification is actually much harder than people think. And most of the existing kind of commercial products don't actually do it very well. We receive images which we have to immediately delete and inform the people that have sent them to us on CD for sort of samples and things that they're just not de-identified properly. And they've just gone on their software system and right-clicked and said send anonymized, and it's just not worked. So you can't really rely on manufacturer software to do this properly. And one of the big issues, you can't rely on manufacturers to conform to standards. So DICOM has standards saying there is a tag called is there burnt in data, and you're supposed to set that as no if there's not and yes if there is. They don't do that properly. They lie all the time. So if it says no, you can't rely on that. If it says yes, you can't rely on that. There's another tag which is called class ID, which tells you what type of image it is. That normally lies. You can't rely on these things. So manufacturers just don't conform to the standards at all, so you can't rely on it, which means your software systems.
Is there any sort of certification for these systems that would say that they comply with this?
They do claim to comply to the DICOM standard, and I think they could probably manipulate the wording to such that they've proven they've complied to it enough. But quite often it's not even a misuse of it, it's actually just there's things called private tags. So these are basically just their own ad hoc tags they can add in, and only they know about them, and only their software knows about them, but they might be hugely important to how the image is displayed. And so we need to learn that information, and they don't tell us that information, so we have to go find it out by looking in the images and investigating. So it's really quite a challenge from the manufacturers. So having a good relationship with the manufacturers is very useful. Unfortunately, we do have a relatively good relationship with the manufacturers, so we can find these things out. And you need to scan for burnt-in text. You can't just do like a simple text detection algorithm, because the text is different angles, different fonts overlaid on body parts and all sorts of things. So it's really quite challenging. So the next aspect of the database that it makes this very useful, the Optimum database very useful, is one, it's very big relatively. We collect from multiple sites. We're able to update our cases, as I mentioned to you earlier. We can keep cases updated, and we can expand very quickly. At the moment, we can collect around about 2,000 cases a day, which is quite quick. And it's fully representative, and by that I mean that we collect all screen-detected cancers and a set of normal and benign cases. We can't collect all, as I mentioned, that would be 90 million or so to make it representative, but what we've done is collect years worth of data. So we've gone to a site and collected, say, all of 2014, so we can use that as our fully representative set. But to do all of that is actually quite a challenge. So some of the issues that are around that are setting up at multiple sites. So when this project was running, it was pretty much just me part-time working on this. So it's quite a challenge to scale up. So you need to make sure that you think about things in advance and make things as automated as possible. So you need to think about the local hardware and storage. Do you have central storage? Do you have cloud storage? It all costs quite a lot as well. So setting up hardware at an NHS site takes somewhere in the region of 5 years to get IG and IT approval. So all of these things are a big challenge. And to be most useful, as I mentioned, the hardware has to sit there for a long time. So you have to be able to remotely administer it for years and years and years to allow these follow-ups to occur. So some of our equipment has been in site for over 7 years now. And we need to be flexible enough to be able to collect new models, new image processing algorithms, new manufacturers, and all that sort of thing. So I'm not going to go into too much detail on that. This is kind of outside of the scope there, but this is our kind of an overview of our setup. We basically have a piece of hardware which we install at the sites, or a VM, whatever they prefer. And then we have bespoke software pipelines set up which are able to query the NBSS to identify a patient, use the patient NHS number to query the PACS, which is where all the images are stored, pull them off, anonymize all of that, de-identify it, store the pseudonyms on an encrypted database, and then upload all of those images to the central location. And then it deletes it all. And then it starts the next case. And that's what it does all the time. So but the bit to focus on is here is the central location. So the scale at which we've got 150,000 cases. That actually totals now to roughly about 180 terabytes of data, which again, it depends on your point of view. That might not sound a lot. If you're digital pathology, that's nothing, but it's quite a lot to us. And so we've obviously had to go to cloud. There's no way, I couldn't ask our IT for a terabyte, let alone 180. So we've had to go to cloud for this. And so we have our collection sites. Here's the site 1, here's site 2, uploading to our buckets in the cloud. But then of course, something I didn't mention is that we apply what's called a research anonymization profile. That means we keep 1 or 2 fields. We do a risk assessment to say that these aren't necessarily going to be potentially identifiable as long as they're not released outside of the research group. And so those are useful for our own research. We need to keep those, so such as site, we need to know where this was taken. But we can't share that information more widely. So any information we share outside of our group, we need to re-anonymize again. So we need to reapply a full de-identification profile to it. So that means we duplicate our data up in the cloud in a separate bucket for sharing processes. So we end up using quite a lot of cloud storage. So our bill's somewhere in the region of 4,000 a month just for this one project in the cloud. So it's quite considerable. So we've learned quite a lot along the way. We've learned that we have to make our collection sites lightweight so that we can easily stick a piece of hardware or VM in there, set it up very quickly. We don't want to be storing anything there. We want to make sure that as soon as possible we upload things to the cloud. We don't have to do anything at the collection site. It's simply get the data anonymized, send away, and everything else is done elsewhere, because that means you don't have to have staff at the collection sites doing anything. So all our collection sites is all automated. We don't have anybody administering them apart from me and my team every now and then check in on them. So that means we need to have smart automated software, and it's not always that easy to get that working. And yeah, storage is really expensive. So moving on to the annotations. So this is finding out the location of the cancer. As I mentioned, this is not done as part of the screening program, which is a real pain. So we've got the images now up on the cloud. So we need to get these to people we're going to pay to mark them up. So these are collaborators, but they're also people that we're going to have to pay for their time to do this. So we have to create ways to make that happen. And this second point is important. Does anyone, if you read this, radiologists often need the paperwork or the access to the electronic patient record system. Why do you think that is? So if we're asking a radiologist to mark up a cancer in an image, why is it that they might need the paperwork that was associated with it? Can anyone think why that is? Why can't we just send the image to radiologists in India for cheap?
Do they use other things like age, for example, to diagnose?
Well, they will do, yeah. But I mean, the main reason being is that when readers read the images in the screening program, they're not finding a cancer, they're finding what they think is suspicious. And then it comes back for assessment, then it comes back for biopsy, and a biopsy is done, and then they have surgery, another biopsy is done to confirm it was cancer. And it's only at that point, at the end of the treatment regime, that we actually know where the cancer was for sure. So it's been confirmed. So we're asking our radiologists not to ask where they think the cancer is, because that's not terribly useful to us. We need to know exactly where the cancer was, which means the radiologist needs to have access to that information about their treatment, and that's only held at the site we collected it from. So that means we're limited on which radiologist readers we can use to mark up these cases. So it means that the sites we collect, we have to have a good relationship with the readers and radiologists to allow them, to get them to do this. The problem is that can be quite expensive. We pay them quite a lot per hour to do this, and they don't do many cases per hour. So to mark up the 7,000 cases we have has taken a long time.
Sorry, can I just ask you,
Yeah, of course.
to be identified in the first place, how do you then back reference?
That's a really good point, yeah. So because the pseudonyms are stored at the site, we are able to, from that research server, provide them with a lookup list. And because they are employees at the site, they are able to look at the lookup list in order to then use the NHS number to reverse it. We have also got ethical approval to allow a client-side app on the browser to do that. So they enter in a SALT up in the top right-hand corner, and it decodes the encrypted NHS number that's been sent and displays it on the screen, removing the need for us to send them a lookup list in advance. But we're not using that yet. We're still doing the kind of simple lookup list. But that's another reason for them to have to be on site, because they need to know the NHS number. So to do that, we've created web-based applications. So in the cloud, we convert all of our DICOM images to PNGs, web compatible. We then stream them to the browser, and they're able to draw little regions of interest like that and answer some little questions, and that gets saved up on the internet. And that's all fine and good. When it comes to 2D, when they're converted to PNG, the compression is quite good, so they're somewhere about 6 megabytes, so it's not so bad. But tomosynthesis is a different matter. These are 2 gigabytes uncompressed. And I don't think Firefox is going to cope with displaying a 2 gigabyte scrollable file. So we've had to write separate standalone software which knows how to interact with our cloud, stream down slices. The cloud has to pre-cache a lot of these. So there's about, say, 60 slices in a Tomo. You have to extract each of the slices, convert it to a TIFF format, and then scale it down to the different resolutions that they'll be looking at, so that the tool needs to know how to then stream those from the cloud. It's really quite a complex process to get them to be able to see the Tomos remotely like that. And so we've written this software, we call it MedX Viewer, that enables them to do that. And so this is how we've got all of our cases marked up. It's been quite a long process. So yeah, one does need to enable this, and they will need the paperwork. This is the point I just kind of ran it home. It's not them saying where they think the cancer is, it's where it 100% was. So other databases have annotated their ground truth with suspicion, and that's not terribly useful, because it might not be a cancer, it might just be something that looks a bit like a cancer but isn't even benign. So I think this is the final one, which is good. I'm getting close to time. So the ability to share the data really is the crux of it. If we've got all this data in the Royal Surrey, that's great that we can do some AI, but what about everybody else who wants to do AI? So we need to get the data to them somehow, but we need to do that in a secure way that complies with regulations and it complies with our ethical approval. So our ethical approval asked us to ensure that we had a committee in place which monitored the access to the database, which administered it and ensured that it was only used for the exact purpose, which is a real big challenge. So I do have a slide, but it seems to not be on this side. I must have sent the wrong version, so I'll have to just talk you through it. So basically, someone comes along, they go, oh, I've heard about Optimum Dataset, that's really good, I want to apply for that. They fill in a form on the web and we get an email. We then send them a little mini grant application form. They have to fill that in as detailed as possible. In there, they include what they plan to do specifically with these images and any information about any ethics that they may have to obtain. Although, of course, not everybody has to obtain ethical approval. Only academic and NHS institutions, but commercial entities might not need to do so. And then we have a subcommittee within the Optimum that review each of those. We review that for its scientific merit. We do our due diligence on the group to make sure the group is respectable, has a good publication record, is from a respectable institution. And when we are finally happy with all of that, and we've had many hundreds of applications, but only have, say, 55 applied, so we have refused quite a lot. When we're happy as a committee, we approve it, and then that gets sent to the Cancer Research UK people. So those are the people that have funded all this, so they own the images effectively. They own the intellectual property for the images. And then they enter into a negotiation with a group to sign a license. So there's a big license which describes how that group must behave with the images. So how long they can keep them, what they must use them for. They must send us an annual report about how things are going and how long they're going to keep them for. And then they must show us evidence that they've deleted them at the end. Now that's a real big challenge. So you kind of get screenshots with RM minus RF written on it and things like that. So that's the kind of process as it goes, but that's the kind of administrative process around it. The actual logistical process of getting the data to them is much harder because we're talking about many terabytes of data here, which we need to ensure that they can download to one location only. The license says they must have one copy of it, so we can't provide a link which they can download multiple times. We need to have a mechanism which restricts it to once. Now, I know they could just copy-paste, but they're not supposed to because they've signed an agreement to say they won't. So the issues we have are how do we share such a large amount of data and how do we keep track of it? So can anyone think why the second point is important? Why is it important for us to keep track of who has what? Leaks is a good point, yeah. We'd like to know if someone leaks it, we've got IDs that we could track it back to them. That's a good point. From an AI point of view, kind of training, testing.
So you don't release all of the test data to everybody, so you keep some.
Well, quite right. So if we give some data to someone and then later on they come and ask us, oh, we'd quite like to evaluate our product, can we do that? We don't make sure, we don't use the same images again to evaluate. Those are the kind of key points really, is making sure that we keep the data siloed. So for that reason, we have a kind of standardized set. What have I done there? There you go. And the last point here is what not to share. Well, that's exactly that. If we want to evaluate, we need to make sure we have sets that have never been seen by AI because you don't have any cross-contamination. Oh, look, I did have that slide. Okay, there's that slide about how people apply. So what we've done is our images reside in cloud. So someone comes along and says, I want 10,000 cases, please. Here's the cases I want. We identify them within our database. We update a relational database linking their ID to these images. They then get a tool we've written in Python, which they log in with the ID we give them. And that tool then facilitates the download of the images from the cloud to their local system. It then logs all of that activity, logs when they did it, and locks down those images so they can never be downloaded again using that ID. One of the things we do though is that the images come in a big folder called images, and the data, the associated data, comes in a folder called data. So if they rerun the tool, the images won't come down again, but the data will update if things have changed. So if we've updated a case because the woman reattended, that will be updated. So the tool facilitates all that, and it logs it. So we learned a lot. What we just have there was not what we thought of in the first place. So I wish it had. So we've learned a lot along the way. So really we should have done a lot more planning ahead and using cloud. The big important point really is that a lot of my time, especially most Fridays, is spent in calls with all the people we're sharing with, trying to help them interpret the data. And so for that purposes, we've produced loads of APIs, loads of libraries to allow them to read information out of the DICOM files, the JSON files, to try to remove them phoning me all the time. But people need a lot of help with interpreting such complex data. So a couple of other points. So we have longitudinal data. That means we have data points where the woman's visited multiple times. Just quickly, can anyone think why it might be useful to have the prior image for a malignant? Why might that be useful?
Preemptive.
Say again?
Preemptive, you might be able
Well, quite right. And in fact, actually, a lot of the algorithms already out there are showing that they can see something suspicious in those 3 years before that humans didn't see. So that's really quite exciting. I'll just skip some of these because I'm starting to run out of time. So specifically, there's some points of the database that make it very useful, and I'm going to highlight those now specifically for kind of deploying in the AI world. So how a radiologist interacts with CAD is something I highlighted earlier. That's still a little bit of an unknown. So there's lots of different ways. Is it as a second reader, so it's acting like it's a radiologist, or is it a decision support system that kind of advises a radiologist, or is it something that triages cases, removes the easy cases and says you don't need to look at those at all? So that's probably still up for grabs, I would say, in my opinion. But there's lots of parts of our database that make those decisions more useful and things that we can use to evaluate. So for example, we know whether a case is malignant, whether it was proven to be benign, or whether it's a suspicious benign. So that means the radiologist recalled it, but it didn't go through for a biopsy, which means they said, no, it's fine. So those three classes are really important because we recall and panic women all the time unnecessarily. So if we can reduce recall by having a system that is better at distinguishing between malignant and benign, that would be fantastic. Everybody would like that. So we can evaluate that retrospectively using our data set. So I've talked about that already, the consensus readers. It's really useful information. So because we have so many clinical characterizations, that means we can use this information here, such as cancer grade, mutation types, in order to focus on cancers that kill, because there's a lot of cancers that won't actually matter if you detect them earlier. That's just a weird thing that I don't really understand, but I'm told that by our clinicians. So there's lots and lots of cancers out there that are seen, and really it's actually could be left to watch and wait. There's actually no need to treat because it's unlikely to kill the woman in their lifetime. So treating those actually might do more harm than good. And so having an AI system that's really good at detecting those ones isn't much use. Having one that's really good at detecting the high-grade, quick-growing cancers that are often very small and missed would be really important, and we can characterize that. And then making sure it's generalizable. Our database contains all the manufacturers at the sites we collect from. So training an AI algorithm on one manufacturer and then testing it on another is a really good exercise to prove that it doesn't generalize very well. And so being able to test that is important. So moving on very quickly. So what about the future? It's kind of obvious, really. We want to collect lots more from more sites, more images, more imaging modalities. We want to expand and take over the world with medical imaging databases. But yeah, it's kind of obvious. We are actively expanding the number of sites we have, but it's a really big process. I would say it takes at least a year and a half to go from starting to set up a site to actually starting to collect images. It's that much administration involved. So one of the things to finish up with is the evaluation. So we are moving now to not just providing information to train and develop algorithms, but actually now to evaluate those. So we've got sets that we are keeping completely siloed to allow us to take a developed product and say, how would it perform in a setting? So these untouched data sets, it's really important that we select our sites and have a negotiation deal with the sites we collect from, that they're not going to share their images with other people, because all of the sites in the UK are being approached by all the AI companies directly to get access to their images. And it's down to those individual sites to decide if they're going to do that or not. It's not a central NHS policy. And so we need to go for a site that is going to agree to say, no, if you're approached by company X, they're going to direct them to us rather than say, here's my data, so that we don't cross-contaminate data sets. So there's lots of little nuances as well, which aren't really being investigated by the big companies. Lots of research groups are looking at these, and these are things that, because of our access to our database, we can look at. And I think it's worth pointing out because I find some of these really interesting. So I don't think I mentioned, but we collect unprocessed data. So this is the modality spits out unprocessed data, and then an image processing algorithm is applied to it to make it viewable by a human. But actually, most algorithms previous to AI have operated on the unprocessed data because the processing loses information. You lose information about the kind of physics of the image formation process. And so training algorithms on unprocessed data so far in our little group has proven that that's actually better. But getting hold of the unprocessed data is really hard. Sites throw it away. So that's something that we've been looking at. So the manufacturers things is interesting. So if you train an algorithm on all the manufacturers at once and then test it on an individual algorithm manufacturer, it tends to do worse than if you train an algorithm on just one manufacturer and test it back on that manufacturer. Again, that's kind of obvious, but that's not what a lot of people are looking at. So we've been messing around with those sorts of things. And then even just down to little things like which processing algorithm is applied. So when a site buys a modality, there's no central body that says they must use this image processing algorithm. They can choose what they want. They can even customize the processing algorithm themselves and change different settings. And those affect humans detecting cancers, so they also affect AI algorithms. So in conclusion, collecting and maintaining large medical image databases is actually, we found, a lot harder than we expected when we set out on the journey. But we definitely think it is worth it because it's enabled quite a lot of work stimulated by the Optimum grant, and it's enabled lots of collaborations for us as well, which is brilliant. That's the end of the talk. And there's lots of people to acknowledge on that, so I haven't bothered because there's too many to put up there. So I should do that at some point. So everybody who's in that is up there. Okay, any questions?